Order, good afternoon. This is the Health and Social Care Select Committee. We are having one of our one-off topical sessions this afternoon, following up on our previous work that we did jointly with the Science, Innovation and Technology Select Committee on coronavirus lessons learned to date. So as well as the Health and Social Care Select Committee members who are sitting around the table, we also have the Right Honourable Greg Clark MP, who chairs said committee. Welcome, Greg. Thank you for coming along.
Thank you.
I should say that Greg's committee is currently holding its own inquiry into COVID-19 and emerging diseases, I believe it's called. So there's quite a broader scope than this just one-off session, and we only have our guest with us for about 35 minutes. And then we're going to hear from Jenny Harries from the UK Health Security Agency. So I will, without further ado, introduce Professor Sir John Bell, who is Regius Professor of Medicine at Oxford University. Very nice to see you, sir. Thank you for coming back. We published that report with the Science and Tech Committee, Coronavirus Lessons Learned to Date, in September 2021, and we did an update session on it, a joint session with both committees together. And I think we last heard from you, November 22, so how time flies when you're having fun. And we haven't heard from you since formally in this committee, but you probably follow the proceedings of the COVID inquiry, as do we all. We catch the glimpses on the news and written reports, and some people even watch the live sessions. What have you learned from listening to the COVID inquiry so far that you didn't know already? And I should just say, this is no time for modesty.
Okay. So to be honest, my impressions, I've been a bit disappointed by the inquiry as it's gone so far. I had hoped that it would lead us to a position where we understood what we did right and wrong in the last pandemic, but also what we could do to deal with the future challenges of infectious disease pandemics. And we haven't really got there. It looks to me more like a make-work program for the legal profession, frankly, because I don't think we've got into any of the real serious detail of the science that underpins it. There's been a lot of discussion about process. You know, I guess one of the implicit outcomes was that if we have another pandemic, it might be good to have a different team in number 10. You know, I think it's I'm not sure how that's helpful. I just don't think that's really germane to the...
Because we already do have a different team.
Exactly. It's very unlikely that Boris is going to pop up again for the next pandemic. So, I mean, it is what it is. But I do think that if I may say so, the report that you jointly did between Greg's committee and Steve, this committee, was actually a pretty good piece of work. And as you know, I was pretty close to this all the way through, and it pretty much replicated my views. Started badly, got better. In the end, we managed to work our way out with some pretty good science and interventions. I think that was really the punchline of how it all played out. And I don't think I would rewrite any of that. It's absolutely the way it happened. And I think your work on that was really helpful.
Okay, well, that's pretty kind of you to say. So, what are the main things that... Cause this session is about reflection, and obviously people say things in the immediate aftermath of a crisis, and many things were said, and most people stand by them, rightly so. But as time goes on, you reflect, and that you just have time to think about things. You see them in the context of other things that have happened since. And I just wonder, looking back now in early March 2024, how do you reflect on our understanding of COVID-19 and our understanding of the pandemic and how we handled it?
Yeah, so I think you're right. My judgment on this has actually shifted a bit, but I think one of the things that you become very aware of is that we were confronting a crisis where no one had really any substantial experience about how to deal with this. And I think it's very easy to be critical about lots of people, but the truth is we didn't really know how to deal with this when we entered it, and what we had to do is we had to learn as we went along. I think we did pretty badly at the beginning. The system was largely unprepared for that particular type of pandemic event. And I do like to remind people, because it's very relevant for the future, that this was a relatively, well, I won't call it mild because a lot of people died, but it was a relatively easy pandemic to manage. The case fatality rates were relatively low. It happened to be a pathogen you could make a vaccine to relatively easily, as we did. It was possible to get on top of it in a number of different ways. It's, I think, very sobering to think of what a real severe pandemic would do to this country. The team at Airfinity, who were one of the best people in collecting data during the pandemic, have run the model and have said, if the original virus that popped up in Wuhan had not been Wuhan, but had been Omicron, just another member of the same family, then, which was more infectious, but would be meeting an immunologically naive global population, the mortality would have been 5x what we had. Well, I can tell you, if the mortality had been 5 times what we had, the whole system would have collapsed. So that seems to me that's what I would call a very close call. If you had a pathogen that killed a lot of young people, teenagers, children, that would have caused all kinds of trouble. If you had a pathogen like the severe, highly pathogenic flus that kill 30, 40, 50% of people who get them, that would have been a problem. So I think, in a sense, we've had an opportunity to learn from our experience with COVID-19. But what's crucial now is we lock in those learnings so that if we did get one of these other really bad events, we would be much better positioned to deal with them. Okay,
and just finally from me, and I'm going to bring in Greg. You said that the UK, when you last spoke to us, you said the UK should be, and I quote, pretty proud of its ability to track variants at scale using genomic sequencing. However, you said the big issue is not what happens in the UK, but what happens globally. It's not hooked up very well. There's not a very coherent way of tracking variants as they emerge globally. There are some databases, but they're not ideal for this. So if I may just then link you to what is a controversial subject that members of Parliament get lots of correspondence on. There's been debates here in the House around the Pandemic Preparedness Treaty and the work that's going on at the WHO at the moment. I just think, what are your reflections on where the global economy is in respect to pandemic preparedness and tracking?
Yeah. So I think one of the things that happened, and again, this is sort of understandable, but it's not helpful, is that we got to the end of the pandemic, let's say the end of 2022, whenever. We had lots of other crises brewing. We had the war in the Ukraine that popped up. We had inflation, energy crisis, all that stuff. And what happened, and this is not a UK thing, this is a global thing. People sort of said, look, we've done COVID, we've had enough of COVID, let's go off and do something else. And so in fact, the pace at which the world retreated from trying to deal and manage and think about infectious pathogens was eye-watering. I mean, it really disappeared. And the global surveillance strategies are a good example. There have been 15 ideas that haven't hung together. There's not a single plan. I'm skeptical about whether the WHO plan is going to be, and the treaty is going to work. I can't see how that treaty is going to get a global system organized. So I think it's something that we're thinking quite hard about with the team in Oxford, about how you get a really coherent system which will pick off variants of a wide range of different pathogens, so that you don't have to have teams of bioinformaticians working on what's going on. It just pops up, and you can do that in an automated way. Then the question is, how quickly can you scale sequencing of pathogens globally? Because, of course, the UK was an exception. UK, South Africa, a bit of Australia. Most places didn't do much sequencing. So we've got to get the world much more prepared to be doing that at some scale so that we know what's passing through the system. And so it's not in a good place.
When you say you're worried about how people have backed off just because of the enough already mindset, which is understandable.
Totally.
But I mean, I would say potentially dangerous. What would you say that we then, as a committee of the House of Commons, could say to British ministers? What leadership role could they take in trying to encourage a bit of some more, please?
So I think there is potentially a system out there that you could build quite quickly. Interestingly, there are really only two sequencing platforms at the moment that could be used for pathogen sequencing at scale. One is the Illumina platform, very good platform run by a big American company. The other one is the Oxford Nanopore platform, which of course is run by a UK company, which is probably ideal because they're portable. You may have seen, but they look like a pencil case, and you can get point-of-care testing, genomic sequencing. I think the UK could reach out and actually, possibly through the Foreign and Commonwealth Office, get to the wider UK Commonwealth community and get people to start working together a bit more effectively, to be generating sequences, but crucially putting those sequences in some kind of single cloud-based database which is validated and which is available for use. The biggest single obstacle is that people don't want to share data. And that, we're not sharing data about people, we're sharing data about bugs. And it doesn't seem to me to make a lot of sense not to share data about bugs, particularly when they could come back and bite us all. So I think those are the kind of things that, the UK could provide real leadership in these areas to get that in a much better place globally. And even if we just took the Commonwealth and got everybody working together, that would be a pretty good signal detection system, widespread around the world, lots of capabilities, high income, low and middle income countries. There's a way to do this, I think, if we wanted to.
They're great thoughts. Thank you. Right, let's bring in Greg Clark.
Thank you very much, Chair, and thank you, John, for what you said about our Joint Committee's report and for your leadership during the pandemic. You weren't just an expert commentator, you were an active participant in the response, and we're grateful for that. Would I be right in thinking it's your view that a new pandemic, a further pandemic, is going to happen at some point?
I mean, I bet the house on it. It's definitely going to happen, so everybody should just get used to that. The real question is, what is the likelihood of that happening in the short term? It will definitely happen in the medium or long term, for sure. And as you know, there are many things pushing humans together with a wide range of different species. We're doing a lot of things that are very high risk. Climate change is not going to help with that because insects are moving all over. So, some of the better estimates suggest that there's a 20 or 30% chance of having another pandemic in the next 15 or 20 years. That's a big number. Now, whether it's a really profound pandemic or one that's not so bad, I think we have to wait and see. But it seems inconceivable to me that we won't have another big event.
You pointed out that even the COVID pandemic could have been worse.
Much worse. I think, case fatality rates of 1% or less for respiratory viral infections, now for people who've lost loved ones, that's a disaster. But, to be clear, from a societal point of view, that's not so bad.
The reason for our Joint Committee report and inquiry was that we thought that you needed to learn and apply the lessons immediately because the threat continues to be there. The public inquiry that's taking place seems unlikely to make any conclusions and recommendations for many months at least. Would you agree with me that it would be wrong if the government and its agencies were to say we need to wait for the results of this inquiry because that would be exposing us to risk?
No, completely. I mean, I think we need to do stuff now. We have to also work with the global community to do more global things, but we have to get ourselves sorted out as well. Look, let's wait and see because they've got years of deliberations to go. But at the moment, I haven't seen any insights as to how do we prepare ourselves better for the next event. Now, maybe that's coming in some future iteration, and that'd be great. But it would be, I think, foolish to wait for that.
Let me ask one more question before our colleagues have questions. So, one aspect of that is the on vaccine production and manufacture, which the Vaccine Task Force made a very big contribution. You were associated with that. The Science and Technology Committee has taken evidence from Kate Bingham, from Clive Dix, from Ian McCubbin, luminaries of that approach. And their evidence to this House is that the lessons have not been adequately learned from the success of that process, in particular the links with industry and manufacturing, and in many cases we've retreated from that. What's your perspective?
So I think what people need to understand is that the to have a really successful vaccine program that could pivot and get to very different places, because we don't know what pathogen is going to come over the hill. So you do need to be able to move quickly. You need different vaccine platforms. You need onshore manufacturing for all those that are hot and ready to go. You need clinical trial capacity so you can test and evaluate them at scale. You need a regulator that's ready to go. And most of those things we kind of got to in the pandemic. But now, post-pandemic, a lot of them have sort of disappeared or certainly contracted. So if you take manufacturing, for example, very early on, I was pretty worried that we weren't going to have onshore manufacturing for the vaccines we needed. Now, in the end, we had people stepped up. Oxford Biomedica did some great stuff. Cobra did some great stuff. We managed to get stuff to happen. It happened that our homegrown vaccine was easy to make, well, relatively easy to make, and we had some good manufacturers that could do it. But that won't necessarily apply to all the successful vaccines. So we do need to have industrial capacity in vaccine manufacturing at scale. As you know, we were behind the VMIC concept, which we thought was a pretty good idea.
Vaccine Manufacturing Innovation Center.
That's right. And the idea there was to make sure you could make small amounts of vaccine at GMP quality, at good manufacturing quality, so that we could test them in phase 2 studies and early phase studies, so that if you had candidates, you could get them out there very quickly. UKR hadn't quite managed to build the thing by the time the pandemic started. So in the end, it got built out as a much bigger facility. That's understandable. That got bought by Catalent. It's now, as I understand it, in mothballs. So we're actually now no further ahead than we were in 2017 when you and I had that idea. That's, I think, a really terrible mistake. I don't know how it's happened, but we've ended up without the capacity to do these small-scale GMP manufacturing kits.
And finally, who is responsible for getting that right? Is it the Department of Health? Is it some other department?
Well, that was built out through the Industrial Strategy Challenge Fund, and the funding actually came through the Department of Business, which you led at the time, Greg. But it had a lot of input from lots of other people. It wasn't, we just didn't have this idea. Everybody, industry thought it was a good idea, academia thought it was a good idea, even the Department of Health thought it was a good idea, even though they didn't put any money in. But we do have a corporate responsibility for making sure the bits that you need to respond properly are in place, they're running, they're operating, they're warm, so that they're always on, so that you can pivot to these things. I think the thing that we learned most of all is if you start from the beginning and you have to turn stuff on, it takes too long. And if you were having a pandemic that was killing lots of small children, for example, or was killing 40% of the people infected, you wouldn't want to be standing there. And we would be, I'm afraid, if we had to start again.
Thank you, Joe.
Well done. I think that's a very acute expression, that always on, that it's not. and that worries me greatly. Okay, let's bring in Rachel Maskell.
Thank you, Chair. Thank you ever so much for coming in again. I've read your comments about the Moderna deal and your concerns about that. Could you set out what those concerns are and why you think putting all your eggs in one basket will have a negative impact around the flexibilities you've talked about to pivot to various pathogens as when they arise?
So I think because, to be honest, we did really well with vaccines in this pandemic. We had two types of vaccines. We had the viral vectors, we had the mRNA vaccines, and they worked remarkably well at taking the edge off the severe end of the disease. And you'll remember, because I think we probably talked about it, certainly Greg and I had talked about it, and that is, it was always our intention to stop people dying face down in intensive care units, which was horrible. And I think we did that. And by the spring of 2021, we'd fixed that problem with the vaccines, which was great. But the truth is, there's a lot about the vaccines we don't know, and we still don't know. And as time goes on, we're kind of getting a better sense. So they don't really stop transmission of the virus. They're not very durable. The mRNA vaccines, durability, 5-6 months? These are not great vaccines. So we need good vaccines for that and other respiratory pathogens. But everybody sort of said, oh, well, we fixed that, and we've sort of walked away. And first of all, I think the Moderna deal is an interesting deal. I chair their advisory group, so I'm quite close to them. They're a great company. They've done a good job. But that's not the answer. You can't go, tick, we've now done vaccines. Oh, my goodness me, you can't. And what is interesting is that the pandemic has spurred a renewed interest in developing new platforms for vaccines that could be fantastically powerful, but they don't seem to have any traction in the UK. So, for example, there's some beautiful work coming out of Pam Bjorkman's lab at Caltech, and that is if you take nanoparticles and you put a mosaic of a whole range of different coronaviruses on a single nanoparticle, then antibodies can cross-link to two different types of coronaviruses or different variants of the coronavirus. And what that does is it makes the antibodies that you generate not directed at the highly variable bits of the virus, but at the conserved bits of spike. So the chances of being able to get a response which protects you against a whole range of coronavirus, not just COVID-19, but also all the other sarbecoviruses, the chance of getting that is quite high. So who's doing that in the UK? Well, I don't get it, actually. There really isn't much going on. And even though the Spycatcher platform, which is what they're all using, guess what? Came out of Oxford. Mark Howarth and others. So, I think these are all examples of us perhaps losing the plot a bit on where we could get to.
In many of our inquiries, we've looked at the regulatory framework, and of course the flexibility has really enabled the work to come forward to get a vaccine into people's arms quickly. What has happened since, and what does have to happen to ensure that we've got that future preparedness in the regulatory framework?
Yeah, so again, regulator did a great job. I think there's no question MHRA was a stunningly good regulator. But as you also know that because of they moved the EMA to Europe, the regulators actually lost quite a lot of resource. They shrunk their capacity. And one of the things that I'm very worried about is we're now subcritical in terms of the number of people we have with bums on seats in the regulator. Where you discover stuff, you develop it, you translate it, you regulate it, and you put it into people. You do need resource for a regulator to work in this modern world, and I think we do need to look quite hard about whether we are giving them enough resource to keep them in the right place.
Just finally, I'd like to ask about skills, because clearly there was a lot of high-level skill which was invested within the programme, which brought us into being able to bring the results that we did. Obviously, there's been a lot of loss of skill, and it's let go. What does need to happen? How prepared does a government need to be? How much skill does it need to retain? And how does it scale up should the capability be required?
Yeah, so this gets back to my always on point. And that is, if you say when you have an event, time to train some people up, you've missed the boat. You just forget it. You've got to have a cohort of people who know what they're doing, who can move really quickly and flexibly, get stuff manufactured, get stuff approved by regulators, test out new platforms. Those people have to be in play. And that's, in my view, that's what the science base is for. And that is not just academic science base, but the commercial science base as well. We need to encourage companies to do things here so that we actually have all their skills and their capacities on shore. Because one thing which we saw for sure during the pandemic is when times get tough, people at the borders go up. And, it's not that easy to shift stuff. Supply chains go south. You can't move manufactured stuff back and forth. We were lucky. We had most things here. But that was more luck than careful preparation. Always on is exactly the right expression, I think.
Just feel the need to slightly clarify something, John. You said about the vaccines and transmission, which of course vaccines are not meant to prevent transmission. But you said when you came to us in 22 that the durability of the vaccines was impressive to the point where you weren't entirely sure that boosters were required. So you're not questioning the efficacy of those vaccines.
So let me explain this. So this, I mean, and again, this is a good example of how we haven't really sat down to think about vaccines, correlates of immune protection. The vaccines stop that really horrible pneumonia. So there are several bits to the COVID syndrome. The worst bit was that inflammatory pneumonia that sent people into intensive care units with very low oxygen saturations, and they needed to be ventilated, and a lot of them died, mostly elderly people over the age of 50. That, I think the vaccines that we started with, 2 doses, that's done. We haven't seen that reappear in any setting.
Right.
What we haven't dealt with is the fact that, if you stand in the tube in January and somebody coughs on you, chances are you're going to get something which is a flu-like illness, head cold, that sort of stuff that keeps you off work for 3 days. It's a classic respiratory virus, a bit like flu, and the vaccines are not very good at stopping that. And there's an interesting question about whether we could get vaccines that were better at that.
I understand. Sorry. Thanks for the clarification. I just because I know people listen,
no,
people listen very carefully here, and I
right.
don't want to set any hairs running that don't need to run. Right, Paul Bromfield, over to you.
Yeah.
Thanks very much, Chair, and I'm conscious of your time, so I want to focus just on one issue, which is the clinical research environment post-COVID, which I wasn't on the committee when you last gave evidence, but you described it then as much worse than it had ever been in my memory. Now, it's an issue we keep coming back to in many of our inquiries on different topics. How do you assess it now? Have there been any improvements?
Well, there are several aspects which remain at sort of a critical point. One is the clinical trial environment is still not good, and there are some reasons for that. Obviously, the NHS is flat out trying to make up get the waiting list down and all the rest of it. But nevertheless, our numbers of commercial clinical trials has been really, really poor. We're starting to make a little ground. James O'Shaughnessy, Lord O'Shaughnessy, wrote a nice report which people are trying to implement, and let's see where we get to, but that would help. But, the truth is, the UK's never been very good at commercial clinical trials, and yet we should be the best place in the world for commercial clinical trials. So that needs a proper look at again, I think, because we could really, look, why would we not want our citizens to be the first to get access to brand new medicines paid for by the companies, not by the NHS? There's so many advantages of that. So I would say that environment still needs quite a lot of work, frankly. There's signs that it may be getting better, but it needs a big push to get it in the right place. Then the second big domain, which I think is actually, again, a really critical piece, and this gets back to the point about workforce, is that clinical scientists, we are having a really hard time giving young clinicians the idea that it might be good having a career in clinical science, running clinical trials, testing and evaluating new medicines, new devices, doing the kind of things that the UK has always had this fantastic reputation for. I mean, the UK has always been viewed as perhaps the home of great clinical science. These days, you can't get young people to fill the jobs. They don't want to put their hands up. It's really bad. And the system in the NHS has not encouraged them to take an academic line. So when if you're a medical student and you have an opportunity to go off and do a year doing some research, you get no credit for that when you're looking for jobs as your career progresses. Where in fact we should be promoting that. We should say, why don't you do that? And if you do that, you get a tick, and that means you'll get to a better place to do your postgraduate training. So anyway, that is a really serious problem, and I know the MRC is worried about it, the Academy of Medical Sciences is worried about it. It's a really serious problem, because if we lose our talent base, we will be in real trouble.
Thanks very much. Can I push you on both of those?
Yes, of course, can.
It's a good point in terms of giving credit for research in medical training. Are there other things we could do to make the clinical research environment more encouraging?
So making it easy for kids to do a clinical research training alongside their conventional clinical training. I think that was the point I just made. I think that's quite important. The other thing is that we don't use, in my view, we don't use the power of the NHS for clinical trials or clinical research. So we've got some great high-powered, top-end institutions. Cambridge, Oxford, UCL, Imperial, there's a list of half a dozen that are world-class globally. If you just rely on those for training people, giving people exposure, or doing clinical trials, you're not going to have any impact. The big district general hospitals, and this is where the recovery trial in COVID was so successful, is that they forgot about the big because the big academic guys didn't recruit any patients, or very few. They went to the big places where most people get seen in the NHS, and they enlisted people there, and they got the staff enthused, and they got people engaged, and they put people's names on papers who never thought they would ever be on a paper, but because they contributed, it helped a lot. And it seems to me that that's something that we kind of just now lost it again, and yet it's so important. And when we talk about leveling up, that's a key bit of leveling up. Why should the folks in Bolton not have the opportunity of being involved in clinical trials the same way they do in Oxford? It should be the same deal. And we could then train people in all those places. We could actually really develop a much better cohort of people to do it. So that if you ask me whether I could wave a wand, that's the wand I would wave, is to make it more systematic across the whole country.
That's a really kind of positive and quite exciting point to make. What if you were waving the wand? We've heard so many times the problems in terms of commercial clinical trials. If you were waving the wand, what's the kind of silver bullet, or at least the top priority there?
So one of the real problems is that we are really slow at getting clinical trials approved. And the problem there is one of governance, and that is if you come here with a brand new drug and you want to treat people with asthma or ulcerative colitis, choose the disease, and you want to do a multi-center study of 20 hospitals or 30 hospitals around the country, each hospital has to sign off a governance approval. So rather than saying, look, let's have one hospital look at this carefully, and then if they say tick, then everybody else is in, and they don't have to go through what we've done is we've left every single institution. And then, of course, if they change a few words in the patient information sheet, it has to go back out to everybody again. So it's designed to go unbelievably slowly. So there are many examples of commercial trials where we get around to recruiting the first patient into the trial about the time the trial stops. So, that it's really not good enough, frankly. I mean, it's a disgrace, if you want to know my opinion. It's really, we have to do better than that. And there's no need for it. There really is no need for it. It's just over regulation. It's unhelpful.
Okay, thank you.
And just in closing, we've talked about top-end stuff, so surveillance, the research, the science, the testing, the vaccines, all that stuff. But it was said that we were in a very bad place as a country to receive a respiratory virus like this because we have poor health. We're too big. We're overweight. We're in a poor place to receive a virus like this. We're also doing a major prevention inquiry, as you know. I just wondered if you just give us 2 minutes of your thoughts on what you think we should be doing as a committee to recommend around that agenda.
Big suggestion, invite me back. I can give you 3 hours on that subject, I could tell you.
I can guarantee you we'll invite you back.
I'll give you 2 minutes just as a starter for 10. So what's really clear now is that we live, about 80% of the time we have a disease. Heart disease, diabetes, cancers, many of those things. We're completely asymptomatic, and yet we're brewing very bad trouble because we're living in a sort of miasma of bad risk factors, obesity, high blood pressure, high blood lipids, whole host of things that are going to cause trouble over time. And we are really, really bad at thinking about how we can prevent disease earlier, diagnose it earlier, because if you do that, you flatten all that late-stage morbidity. And the problems of the healthcare system turn out not to be some rare type of cancer where people have got a drug, but there's only 100 cases in the country. Look, terrific, that's great. But the truth is the problems are obesity, diabetes, cardiovascular disease, asthma, mental health. And guess what? We're no good at any of them. We don't have services for obesity. We don't have services for mental health. We don't have services for prevention. It's a mess, actually. And that applies both to the research agenda, which has not been targeting those things, but also to the clinical agenda. So I think that's a domain where there needs to be some really serious thought about how we create a structure that will enable prevention, early diagnosis, and a different type of healthcare than what we currently offer.
We are doing our best. Professor John Bell, I wish you'd say what you think when you come before us. It would be so refreshing. But as ever, you've held back completely. Anyway, I joke. Nice to see you. Thank you very much for your time. We will let you go, and we will seamlessly slide our second guest into your seat while Sandy changes the name. So that's Professor John Bell, who's Regius Professor at Oxford, and replacing him there is Professor Dame Jenny Harries. It's very nice to see you, Jenny. Jenny is the Chief Executive of the UK Health Security Agency, very familiar face from the pandemic news conferences. She's still here. She's a survivor. And obviously a familiar face to this committee and to Greg Clark, who's guesting with us today. Jenny, as you know, the chair of the Science and Tech Committee, who you saw last week, I believe. So, yeah, you can't get away from us. We work together. So you remember we held our joint inquiry between our joint committees looking at COVID and the lessons learned, and a lot of the things that we put in our report back then are obviously well known, and Professor Bell talked to some of them. The COVID inquiry clearly trundles on, and you heard what Professor Bell said there at the start. How do you think the COVID inquiry is going at the moment in terms of helping you do your job?
So I'm sure you're familiar, Chair, with the fact that I'm a senior civil servant, so it's probably not my place to comment precisely on what the COVID inquiry is.
Is it helping you do your job?
I mean, it is, I would say on one hand, it's a huge amount of work, and that has both positives and negatives. It takes considerable amounts of time for every senior individual in my organisation, sure, in a very big way. I mean, on a positive side, it does allow you to revisit and keep challenging yourself, and on some of the points that Sir John was just mentioning, actually making sure that we are progressing some of those things. And I would really welcome the opportunity just to put perhaps a more positive position on some of the points that have just made. Would that be all right to do?
Please do, now? Yeah. Because I mean,
I mean, I'm sure you'll ask me on many of them, but there are things that strikes me from the pandemic and pandemic preparedness and all the work we do. There are things that we do quite well or we've improved. There are things that we still don't do quite well and we need to improve. And then in the middle, there are things that some people know are happening and other people don't. And sometimes we get reports that things are not happening. So if I just use the previous example about clinical trials, and actually it's not my responsibility, it sits very much in the Department of Health. But I think there was a huge move to reset the clinical trials agenda for all the reasons which Sir John said, which I fully support. And there was a report back from the Department of Health on the O'Shaughnessy review. I think he mentioned turnaround for commercial trials. All of them are now being done within the 60-day trial approval time. We have, on average, we're recruiting more than double the number of patients into commercial studies than we were pre-pandemic. There's a new decentralised model of clinical trials, so that picks up the Bolton issue, and the goal for 80% of all open studies to deliver to time and target by June 23 was met. So I just want to put a slightly different angle on some of these, because I often find, I mean, I chaired a meeting last week with the Pandemic Science Institute network, and that was really helpful because it allows all of us to put in what we know is happening and what we don't know is happening, and get a wider picture. So it's just, you know, I could have given an entirely different narrative on the genomics use, for example. So you ask questions about how that's working internationally. There's an international pandemic surveillance network supported by WHO set up in Berlin. UK Health Security Agency has actually, I don't think we've got anybody there just at the moment, but when it was setting up, we supported that. I've actually co-chaired the leadership group for that. UKHSA has a programme called the New Variant Assessment Platform, which allows us to support other countries. So we work in 9 different countries with 7 different regional teams, supporting the development of genomics for those countries. And whereas it is to support the country to grow in their capabilities, it has added benefits because it allows us all to share data routinely. So there are a whole host of areas which I think are happening. One of the issues is not everybody knows that they're happening, and I think that's an important point for the committee to understand.
Well, obviously, equally important point is that you know it's happening.
Yes.
But if I go back to some of the recommendations, right, from our joint report, we talked about our pandemic planning, some of which went on when I was at the department. I put that on the record, I have before, was very inflexibly based on a flu model, which failed to learn the lessons from SARS, MERS and Ebola. This meant that our planning, and we said in our report, performed less well than other countries where it was needed most. We talked about trying to manage the spread of COVID through the population rather than trying to stop it altogether. We talked about groupthink. We talked about the social care sector not being adequately represented on SAGE. We talked about stopping community testing very early in the pandemic. We talked about the successes of the vaccine programme. I just wonder, because you know how I worry, Jenny, following on from Greg Clark's questions to Professor John Bell there, is never mind another few months, it's perfectly possible that the COVID inquiry will go on into next year, which will therefore span the next government of whatever colour. And from what I've heard today, we don't have time for this bureaucratic train to trundle its way through the British state while travelling around the United Kingdom on its tour to Cardiff and Edinburgh, examining the personalities and who said who to what when and who sent which text message to whom. So that's why I worry, is that you can bet your house on it, John Bell said, there'll be another pandemic, and it could be before this inquiry reports. So give us, as the select committee that scrutinises your work, give us the reassurance that you're not waiting for Godot, that you are on the case with pandemic preparedness planning for the next one.
I will. So the inquiry, I think, is not anticipated to end at least until 2026. That's quite a daunting prospect if you're sitting in my position, because of the number of modules that are scheduled through as we go forward. I think that's common knowledge. I don't think I'm saying anything out of turn. So, and exactly for the reasons which you say, I mean, clearly I want to take the learning from the pandemic, and as the first module reports should be fairly soon, then we will take that. And I think we are, to a degree, waiting to finesse the work that we're doing, if you like, to check up on that we have thought through all of those things. But that's not what we're waiting for to get on, because there were some very obvious points of learning from what we've done already. I mean, we could see as we were responding to the pandemic, there are opportunities to proceed. So I'll skim through a few of them, and then you might want to hone in on some. So, for example,
just 3.
Give you 3. So, systematic preparedness about detection and surveillance. So, the Joint Biosecurity Centre was established during the pandemic. That now forms our data analytics and surveillance group. It's a priority group and a new area of development. We have fabulous people led by Stephen Riley, who actually led the REACT study when it started off. We are majoring on that, and what we're doing is, I think, 2 things I'll flag. One is the systematic analysis of data, so trying to work so that we have gone back through, looked at what we think are priority pathogens, where all our data comes from, how we report that, and we're working through a steady programme, firstly of trying to digitally link that. So, as I think Sir John was saying, actually, this data just trips off. Nobody is processing it. It trips off and triggers, if you like, so that in due course there will be a much more automated system and a wider data set. But I think importantly, the government has put in train work on a new biosecurity strategy, which is published, and we are leading work to explore. It's still in the sort of pilot phase of trying to understand whether we can develop a quite ambitious One Health biosecurity surveillance network. So that is looking right across government at every department. So, I mean, obviously, if I said something like avian flu, you'd say, actually, well, you know, or swine flu, have we got all those data links systematically coming in together? And it's our responsibility at the moment to try and see if that is a possibility for the future, and we're leading that piece of work. There are a number of others as well. So I think that's surveillance, and there's good work on that. What would I go to next? Diagnostics. So during the pandemic, I think you will be aware, PHE, then Public Health England, did a very rapid turnaround on coronavirus tests, but that was built on scientific work that had been in train with WHO before. So they had been participating with WHO on developing a pan-corona assay that you could then tweak, if you like, when the coronavirus came. We now have in Portland, we have funding 3.6 million from CEPI to support onward development of pan-coronavirus assays. So this is about getting ready ahead of time so that we're at the nearest possible place to have a diagnostic test. Because of course, if you don't have a test, you can't find out who's actually got the virus. So that work is ongoing, and that fits in with the development of investments during the pandemic in a vaccine development and evaluation centre at Portland Down. So that's going. And then linking that then to vaccine development. So John obviously mentioned the Moderna partnership, but again, I would just like to quash one of the narratives which is around, I think, just because there is a partnership with Moderna, and it's a very significant one, which we can come back to, I don't think that means automatically that no other vaccine platforms are under consideration. And I would totally agree with Sir John that actually we need all sorts of vaccine platforms. We don't yet know what the long-term benefits are. And my sense is that mRNA, for all the reasons which he said, is a really good one to have ready to hand to go for a new pandemic. But for longer-term control, you may want to use a different platform.
And is that because mRNA is, using my layman's terms, it is very flexible and very pliable, and you can tweak it to do what you need it to do to latch onto the virus?
Rapidly. Yes. And so when, for example, when we had the new swine flu variant, which I was talking to the Science Committee about in November, I did have some sleepless nights. I don't think that probably filtered out into the wider public, but that could have been the start of the next coronavirus pandemic. And we did a run-through, if you like, of how we could do our test scale-up, and then if the Moderna factory, if you like, was up and running, which it's not at the moment, but should be within the next couple of years, 18 months to 2 years, would we be able to process that through? And one of the challenges there is about the 100-day mission, is to say, actually, what can we do?
This is the G7 piece of work.
It's the G7. It's an ambition. It won't work for absolutely everything, but the idea is to get from a pathogen to tests, treatments and vaccines within 100 days. And we think probably we could. Now, there's all sorts of ifs and buts about that, but it starts to put things in a completely different picture, because actually, if you can do that, and you've got early warning from somewhere else as well, because your surveillance is different, and actually you've developed different testing capacity, so you've automatically tweaked your lateral flow test, for example, because you've developed your assay earlier, all of a sudden you have a different control scenario, whereby you may have early LFDs. We're still continuing to test all the lateral flows coming through with new variants in Portland Down, but you'd have early assays, LFDs going out, so you wouldn't actually need all the infrastructure for average community testing. You would definitely need it for monitoring variants and developments. And you would have a new vaccine quickly. Now, that's probably one positive end of the spectrum, and I'm probably positioning it that way because the conversation earlier was quite negative, and the reality is probably sitting somewhere in the middle.
Very good. Okay, right, James Morris.
Thank you, Chair. I wanted to bring us down to the sort of impact on social care of the pandemic. And I mean, in the original report from this committee, the report said the experience of the sector during COVID was one of intense stress, with some decisions made which caused the experience of residents and their carers to be more difficult, and which sadly likely to have resulted in more deaths than was inevitable. And as the Chair said, and as we've discussed, it's possible that a pandemic could hit us next week. Would the social care system be in a better position than it was in 2020?
I think the answer is yes, and I'll come on to why. But it is an area that I feel very strongly about. I think it has historically been dissociated, if you like, from healthcare, and it is actually one area I've put on record in my personal responses to the public inquiry, where I think there is a lot of opportunity going forward. We will never remove the fact that these are the most frail, vulnerable individuals in society. That's why they are being cared for, and we have to bear that in mind when we're looking at outcomes. But I think there are a couple of areas that I would particularly flag. One is, I think there is a lack of research on what I might call the balance point. And in fact, I personally tried to enable some of this in the middle of the pandemic when I was chairing the social care SAGE subgroup, because, as you rightly pointed out, individuals are something which may seem more obvious in terms of infectious disease control for the general population is very challenging when you have individuals who are responsible, if you like, for their own health and what they choose, people caring for them, and then any actions of those also impacting the care and outcomes for other groups. So we're into quite an ethical minefield, and in fact we did actually consult with ethical colleagues in the middle of the pandemic. But what I was trying to do was actually understand, we tried to put in place a piece of research to say actually what was the balance of risk, if you like, between something like an individual not receiving a visitor, which is really, really significant for somebody, particularly if they're suffering from dementia, to the risk of infectious disease itself. And for a number of reasons, we couldn't do it during the pandemic because it relies eventually on somebody making a value choice. And
Can I ask a specific question? There were quite a few people in the care sector during the pandemic, the beginning of the pandemic, who were warning the government or warning the authorities about what may happen. Do you feel as though their voice is being more listened to? Have you got processes in place to listen to the concerns of the social care sector in a way which was different from what happened at the beginning of the pandemic?
I'm not sure to whom you're referring in terms of, that's quite a general statement.
Well, if you take that, I mean, I was aware of, the National Care Association and other bodies were making, were issuing concerns at the beginning of the pandemic about the impact on the social care sector, what may need to be done, the fact that it was very fragmented. How can we be confident that we've moved beyond that?
So I'm not able to ask. The system that we have in the way that the care system is set up is clearly for ministers and government to decide, and I don't think I can comment on that. What I can comment on is what we have done to try and improve the context in which we're working. So one of the really successful pieces of work, and it has very practical implication now, was the Vivaldi study. Yep. So when it was clear that there were a high number of deaths in care homes very early on, a small study was put in, which we refer to as the Easter 6, and it was done over the Easter bank holiday to try and get some signals about what the risks were and how we could manage them. And that moved on then to the Vivaldi study, where we worked with Professor Laura Shallcross from UCL, who has led some fantastic work. There were 3 phases of that Vivaldi study, and in fact she used to come to the Sage Care subgroup, and we used to pick up the findings. We'd check how robust they were. You don't want to take research before it's conclusive, but where it was very clear there was a signal. So for example, about care home staff moving between settings and the risk of infection transfer, we would then take that and feed it directly into discussions with the care minister in order to manage the risk. So that was hugely successful. What we've done since then, and it was a key problem at the start of the pandemic, was because it's a fragmented system and it's not a national system, there was no single national data source. And so actually getting routine data and understanding routine surveillance, we get outbreak information, we have a lot of knowledge about care homes, but it wasn't done on a normal surveillance basis. So what we're doing now is, Vivaldi stopped at the end of April last year. We've put in a pilot programme which UKHSA is funding, and then working with Professor Shallcross to see if we can, it is on a voluntary basis for the care homes, but there's a lot of interest to establish, if you like, a routine surveillance system for care homes. We're aiming to get somewhere between 500 and 1,500 care homes feeding in, and that should give us, as long as they're representative, and there seems to be generalised interest across the care sector.
So just a final question. So in the kind of nightmare scenario that a pandemic was to emerge very quickly, would you be confident that you'd be in a position to advise ministers that we have better data surveillance about what may or may not be going on in the care home sector, and also that we would have better protocols about how we're going to deal with the impact of a pandemic on the social care sector? Would you be able to say that?
I think we have progressed. I think there is still work to do. I think what I've just described is still a process. I mean, it's new, so but I think it's starting to answer your questions. And part of that work as well is about training in care homes as well. So if you train and we work with individuals, can you improve outcomes? And that also then would be able to inform any new infectious disease outbreak.
Yeah, thank you. All right, thank you very much. Right, we're going to go Chris, and then we're going to go Paulette. So starting with you.
Mr. Chairman, Professor Harries, last week on the Science and Technology Select Committee, you asked a question about the data around excess deaths, and you were quite cautious about supporting the release of that data, but you said you look into it. Have you looked into it? Have you...
I'm reaching for my piece of paper, and I think the issue. I now understand that the question related to there was a letter which I think has gone to my own organisation. It actually went to Professor Riley, which was why I hadn't personally seen it at that point. So and to Secretary of State, and I know a formal response will come back to that. I think there were a couple of key points about that. One was about the data that had been shared, and there was a suggestion. I think the UKHSA had shared mortality data sets with pharmaceutical companies. As far as we can see, we're still obviously will do a formal results. We don't routinely share record level mortality data sets that include vaccination dates, doses, and or comorbidities with any of the pharmaceutical agencies, and that was, I think, the main point of the question. We have received a Freedom of Information request on that information, and we're trying to understand what we can and we can't release. And we have released anonymised aggregate data to manufacturers. This is for their own vaccines to support their obligation to report to MHRA as part of the routine safety surveillance. But these data are commercially sensitive. Now, I think the other thing is, the conversation started about excess all-cause mortality. Excess all-cause mortality is based on aggregated data, and it only signals, and I do just want to flag the sort of realities of this, because to report an excess, you have to have a baseline as well. And so for something like flu, where we would normally report an excess mortality rate for flu, we know that flu goes in seasonal patterns. We know what the baseline is, and then you can give an assessment. Now, for COVID, actually that hasn't established in the same way, so I think it's important that people understand that as well. Since COVID-19 vaccines were introduced, my organisation, UKHSA, has worked with MHRA, ONS and other academic groups on vaccine safety, and those are led by MHRA, hence I think my comment back to you, Chair, for the Science Committee. But I think an important point as well is there are very large data sets on things like open safety as well, where vaccine mortality has been looked at, and it's actually shown protective effects for when it's actually restricted to non-COVID mortality. So if you're looking at people who have not had COVID but have had a vaccine, actually there is no increased risk. So this is stepping right away from some of those risks. And if you just look generally, if you look at countries which have had higher vaccine uptake, they have lower excess all-cause mortality. That's quite generalist. But I think the key point here is we have looked. We don't routinely share. We will look. There is a commercial sensitivity element around this, and we will answer that question very soon in full.
Yeah, I appreciate that answer. I also appreciate the concerns there are over sharing patient data. I also appreciate concerns that with significant sets of data, it's quite easy to find patterns on it which actually don't mean anything or can be interpreted perhaps in a wrong way.
Exactly.
Touching perhaps on one of the concerns I had during COVID, particularly before the second lockdown, was the impact assessment about you've gone through one set of lockdown for a long period of time. Society had, whether it's the economy, wider healthcare access, children's education. So when I visit schools in the constituency now and I ask, has there been any impact or what is the impact over COVID or the lockdowns, teachers will still tell me there's a really significant observable impact on children's educational performance, also the way they interact with other children and wider society. So, and you were talking before about surveillance as well. So I'm just wondering what your thoughts are in terms of if we were, and we've been discussing about the potential probability in the not too distant future of a further pandemic which could be significantly more severe, what commitment do you have to making sure that more data is more available to appropriately skilled people, but more data is more available so we can have that proper national debate during the course of the pandemic, which I don't think we really did during COVID-19?
So, I mean, this goes into a much wider consideration than just UKHSA. So, for example, data on school attendance or impacts on schools is not sitting with myself, it's sitting with Department for Education, and we could multiply that around. Impacts on economic impact will be sitting in other departments, and I think that's why actually in the public inquiry, but I think we all recognise that breadth of impact on the country is why it isn't just an infectious disease issue, and I think all of my colleagues would recognise that as well. Where schools in particular, clearly education is really important. That was recognised all the way through. I mean, I'm a generalist public health physician, and I recognise that from working as a sort of jobbing director of public health and the importance of that. Your question, though, is about actually how do we do that? Now, when you're doing it when a pandemic is running, and as Sir John flagged earlier, he has noted we could have a really difficult pandemic. Let's suppose that we had a pathogen which absolutely targeted children. That would create a very different set of circumstances for understanding whether it was safe or not for children to attend school and where the balance of risk is. And I think, as CMOs often said, these are all, none of the decisions, I'll paraphrase him incorrectly, I'm sure, but none of the decisions are good ones. It's going for the least worst one.
Well, that's where I think it's so important in terms of that scrutiny, where COVID didn't have much of an impact on children, and that question of whether or not schools should have been closed down is one thing. I get the sense that people would have rather schools were more opened up, but yes, if the pathogen had targeted children, obviously you'd have a societal support for that kind of isolation, preventing that transmission. It's just that kind of commitment to a slightly more open approach.
I think everybody recognises that education is really important for children, and nobody wants to close schools unless it's absolutely important. Schools were generally the last to close and the first to open, and I think all the UK CMOs actually put out a statement recognising what the risks were and trying to support that. It is difficult, I think, when you have, it's very easy to look with hindsight. This is one of the problems with the pandemic. Everybody looks backwards and said, well, now we're at this point, we could have done X, Y, or Z. When you are in the middle of a pandemic, and this will happen with the next one, which I totally agree with Sir John, we will have one, when you're in the middle of it, you're dealing with trying to characterise the pathogen, the impact at the time. I think, though, that where we can go. In fact, we've got a number of different strands of work. We are looking at where the evidence gaps are, so working with all the pandemic science institutes. So Liverpool, for example, did some really good work. We have what we call twin hatter academics, so they're half with us and honorary contracts with UKHSA and work in academia. And just this afternoon, Ian Buchan, who works in Liverpool, has just sent me, he's chairing a group right across the academic sciences, looking at things like the testing programme, but also which pieces of evidence we didn't have, and that includes non-pharmaceutical interventions.
Thank you. Thanks. I hear you. What you're saying is hindsight's a wonderful thing, and everybody has 20/20 hindsight vision. But another word for hindsight is experience. And I just wonder whether you feel that we are, as a society, through the inquiry or through anything else, getting to the nub of that trade-off. Because, yeah, sure, in the middle of a novel coronavirus, when we didn't know what we were dealing with, in the early days, of course, we had to take the action that we did, and this House supported that by and large. But there were impacts to that, and we're now seeing them big time in the school system, everywhere else. And so I just wonder whether you think those coronavirus lessons are being learned and are being examined, that there's a trade-off between action as well as non-action.
So there are two parts to that. Is the trade-off being recognised? And I think that is the case. And I would say I'll come back to some other work that's ongoing. But secondly, where the decisions for that sit. And I think this picks up a point that was made in the public inquiry, which is this is a whole government decision-making process, because there is a balance of intervention, and it's important that there is equivalent evidence from all areas, whether it be economic, whether it be education, whether it be infectious disease, that come together. So if I put my Director of Public Health hat on, I absolutely understand the impact on the social sense in communities. That's where I started my working life.
Yeah.
But actually, I need other departments to come in with their data as well to balance those. On a more positive note, I think, one of the areas which is being developed, so this is with the Chief Scientific Advisor, Lucy Chappell, in the Department of Health, and ourselves as well, where we have health protection research units funded by the National Institute of Health Research, and whether it be a particular pathogen, evidence gap, or wider areas, there is now a cross-government funding research framework. So what it starts to do is say it could be this pathogen group we know nothing about, and yet we've flagged it as a highly likely risk going forward. We need to understand more. We might need to develop tests, and focus on that. But equally, it can be used to focus studies around some of the, if you like, the social balancing risk, I think, with academic colleagues.
Interesting. Okay. Something completely different, as they say. Paulette Hamilton, can I ask about something else?
Hello. Good afternoon, Dame Jenny. Let me start by saying I wasn't in the House when this all kicked off. And in the communities, we saw at first hand the hell that was going on out there. I felt we tried to feed into the process, but we weren't listened to. That's the premise I'm coming from. Professor Bell actually highlighted that we did particularly badly at the beginning. But by the time we had started to really look at numbers, large numbers of the ethnic minority communities in proportion to other communities seemed to die at that point in time. And we lost their trust. And at a local level, I know we lost their trust very early on. So what that meant was when the vaccine was actually produced, the great work was done. So we actually went to the point where we were doing some good work. We'd already lost the trust of large numbers of our communities because they had seen lots of deaths and they just didn't believe a word we're saying. Let me say that at the moment, in my humble opinion, because I can't profess this with any facts at the moment, we seem to be seeing larger numbers of deaths in the African, Caribbean, Asian community and others, of people that didn't take the vaccine. So the question I want to ask you, is any work being done to check or identify what long-term outcomes are there for communities that actually didn't take the vaccine? So that includes the indigenous community. What work is being done to actually, what is happening to those groups that didn't take vaccine 1, 2, where did I stop? I think I stopped at 4, 3, 4, and I think there might have been a 5th round, I can't remember. But there are many people that didn't even take one vaccine. And Professor Jenny, I think there's a big gap here developing, because I'm not sure what work has been done to say people are dying. Some of it is weakening from coronavirus and then they've passed away, but it is not being identified.
There's quite a lot in that question.
There is, and I'm sorry about that.
So I'm going to make, so I probably won't be able to answer all of it all at once. Yeah. And I'm going to, for local communities, so often there will be communities who are much better understood by their local authorities and particularly by the directors of public health. So one of the key points here is a director. So if I was back with my DPH hat on in Norwich, for example, in Norfolk, I would know my local communities very well, and at this point I would have a very good idea, for example, of where children were not confident to be going back to school, or about where particular hotspots in my county where vaccination rates were low. Now, at national level, we do geographical assessment, for example, of vaccination rates. I mean, clearly the COVID vaccine is one which has been universally available. I mean, in many ways it's quite unusual because it was prioritised for clinical need, absolutely. It was absolutely available for everybody. So I think in many ways my most concerning point from what you're saying, and I do recognise this because I've just been dealing with measles and I might come back to that.
Yeah, that's my second question.
Well,
this is leading towards the measles.
Well, maybe I can put the two together then, because one of my parts of sadness, I think, from the pandemic is we have had a very good vaccine development system, we've had a good rollout, and we have people who are still not confident to have a vaccine. And it is those people who are likely, and the communities often with the highest rates of underlying health conditions and the highest inequalities, to continue to differentiate that inequality and grow it. So we will see a continuing divide.
So has any work been done to actually, because sometimes if you give people the facts, that will help to make an informed choice. So has any work been done to actually say to this group, this is what is happening, this is why it's been happening, and we believe other choices would come to different conclusions?
So yes, so the NHSE, so they mostly deliver the vaccines on the ground, if you like. We do the advice, evaluation, the scientific behind it. We do much of the assessment of the assays and things. But NHSE delivers this on the ground. Now, they published a new vaccination strategy, I think it was November, December, highlighting the learning, if you like, that actually to reach some communities, traditional methods just don't work. You can't just put a thing out. People aren't confident. So actually recognising the fact that the messaging has to be from somebody that the individuals trust. So that is absolutely acknowledged. And the new vaccine strategy is designed to do that. And if I might say, I was up in West Midlands last month and I was in Liverpool on, I'm losing track of the week, Thursday afternoon at the Florey, where they had been doing some really interesting work. So Liverpool Council, NHS North West, DHSC, a whole host of people, but particularly on a health equity project. So I actually went to the community group, and I'm hearing exactly the same thing in Birmingham as I'm hearing in London, which is its small communities need individualised, and this is quite difficult for delivering national programmes, they need long-term individual connectivity with people they trust. It's no good actually just going in and saying, there's a measles outbreak, grab this vaccine. Now, for some people who just haven't quite got round to it, that's great. And I'm sure we've just launched a new campaign today designed to support people looking through the eyes of children. And for those people who just haven't got round to it, it might just remind them these are serious childhood diseases.
Which I understand, Dame Jenny,
Yeah.
I really do, but I'm going to go back to my original question. Is there a piece of work being done with, say, a sample cohort that didn't take the vaccine to see what's happening in those groups between the ages of, say, 50 and 75?
There's loads of work, that's what I was saying. So the work that I'd attended in Liverpool was
It isn't just about, though, taking the vaccine. It's about what is happening to that cohort of persons that perhaps didn't take the vaccine. You can't engage them, but using your GPs, primary care and others to do like some health surveillance of what is happening to, say, a sample group of people that perhaps didn't take the vaccine, what's happening to them. I'm just asking, is there
so I
anything
think
being done?
we wouldn't have, because with the Health Protection Agency, I mean, there'll be a number of other, GPs will have their individual personal records about their health
So
outcomes.
we're not doing it. That's all
No,
I need
I'm
to
not.
know.
I don't think I'm saying that. I think what I'm saying is I suspect that there are some research programs which we are not involved with, and we can, of course, predict what's going to happen with COVID, because many of them will have COVID infections and will have serious outcomes from it. So we can predict before we even do the piece of work that it's going to be negative, which is probably why I was focusing my response very much on actually what the approach is to try and support people to understand the risks from that.
Do you want to do measles?
I do want to do measles. With the measles vaccine, long before we had COVID, we have seen the take-up rate for measles, MMR, going down in local. Take it across the board. It isn't an ethnic minority thing. Going down across the board, and this was happening prior to COVID. Do you believe that some of the reduction in funding around primary care, where they are not getting that support that I perhaps got when my children were younger, has anything to do with the fact that the take-up rate has started to reduce? And the reason I ask that, and I always do this, I try to build it up. The reason I'm asking is because there's this new narrative around get communities to help them to support themselves, to actually get to increase the take-up rate. The problem I have with that is, at the moment, DPHs, their funds, the ring-fence public health fund is at the moment, it's in a bit of a critical state. They're not getting the financial support to do any of this work, and people are asking them to do things that, in my humble opinion, they are able to do, but they need more staff, they need more resources. This is money, and it is not being given to them at the moment. And also, I am very concerned about primary care and the support. If we're talking about intervention, early prevention and intervention, primary care is key to some of this. And at the moment, I just feel the words are being bandied out there, but how are we truly, from national downwards, down upwards, working with our communities to make them more confident to go out there and take these vaccines?
So I'll have a go at some of those. So I think primary care is clearly really important. We know from our research that despite that drop-off, that most young families, more than 90% still, are confident in the vaccine programme for going and delivering for new children. And what seems to happen is that they'll pick up the vaccine pretty well, so reasonably high uptake for the first, when we start at 8 weeks, 12 weeks, 16 and what have you, and then it tails off. Now that's not unusual for vaccines in the sense that people need to be prompted to come back in. I think there are two or three reasons that there are potential issues. I think the Directors of Public Health they don't deliver the vaccine itself. They kind of do what I'm doing here at the national level to their local communities, and they were doing a fabulous job. So I was with the DPH in Liverpool and Greater Manchester last week, and they are working absolutely with and doing really well. I think we're all sitting and scratching our heads, which was why I was there, as to why this rate it's dropping by about 0.1% per quarter, and there are two or three main issues. One is, we think, not necessarily a particular issue with access, but convenient access is important. And we were talking about pharmacy, who of course played a really strong part in the COVID programme, and that's not in most places available for childhood vaccinations at the moment. NHS are working to see if they can improve the data linkage to make that another point of access, which would be really easy for communities. Second point is, lots of people just don't think these are important diseases. They're not used to seeing them, including some of the clinicians. So they think measles doesn't exist anymore, and that one got solved. And of course, actually, the rates are starting to rise, and we will have and have had serious complications from those infections. So there is something about raising awareness, I think, about the reality of these childhood infections as well. And then I think there is this, with definitely a point about trusted, so whether it's the GP, there was a passionate GP working who was getting really good uptake, working in an area where high residents of Orthodox Jewish community, Haredi Jewish community, with excellent take-up, but it was the direct trusted linkage with that community and answering the questions that they wanted to ask. But I go back to my earlier point, which I think is potentially linked to longer term funding, and as a senior civil servant, I'm probably not going to stray too much into that point, but the continuity of the connection with individual communities, which is where the Director of Public Health comes in, is critical, because it's very clear messaging that communities do not want you to just turn up one day and say, here, have this vaccine, it's on your doorstep now. It has to be a longer term relationship, and I think that has been lost to a degree.
We probably better move on. If that's okay.
I was going to ask what to tie it all up, but you can move on.
But you can bring that in, and because it perfectly links to our next question from Rachel Maskell around Directors of Public Health, and as we return to pandemic preparedness. So Rachel, pick that up, please.
Thank you. I'm also conscious you've been in the hot seat for nearly an hour, so I've got a couple of quick questions. We've talked about the international and the national, but clearly the local played a really important part. And certainly working with my local DPH at times, knowing that if DPHs had more freedoms to drive the local response, that they would have been able to protect health and life more so. Where is the balance sitting, and how are DPHs going to be more involved in being able to provide for their local communities and work with other actors and infrastructure to be able to get a strong local response in the future?
So you'll know from what I've just said that I've been a Director of Public Health both in England and Wales, so I'm very familiar with that. And whenever I'm thinking, although it may not always seem that way to them, I always start my national thinking by putting my Director of Public Health hat on, because that grounds you in reality about whether something will work with a family in a local community. I think that we can't do the national job without Directors of Public Health. They can't do theirs without the Health Security Agency, because we've got the specialist expertise. We provide huge amounts of stuff to them. So, vaccine campaigns, for example, they don't have to do any of that work in the sense that we're providing it. Where it works well, and we try to do this with them, and I link with them, I've got many of them on speed dial sort of thing, is trying to get the boundaries right. And it's easier to do, obviously, when things are slightly slower moving than it was at the start of the pandemic. Immediately after the pandemic, we kicked off a piece of work with Directors of Public Health, so with the Association of Directors of Public Health, on what we call the Future Health Protection System. And it was to try and work out how we could make those boundaries absolutely work. What happened in COVID was, effectively, because there was a an unprecedented need, we ended up with 2 parallel systems effectively. And so when I came into post, knowing both bits of the system, I tried to glue them back together in an effective way. And I hope we're heading that way. It won't always be perfect, but if, for example, we have our DAS, so data analytics and surveillance grouping, I think we've got about 120 data agreements with local authorities now, so this starts to address some of the data issues. I do meet with them regularly, CMO does as well, and there is a national public health senior group which meets as well to try and sort of informally flag where there are issues. So, we had a conversation the other day on I probably shouldn't bring this in because it'll on migrant health. Let's just say, to say actually, do we all have a shared understanding of what's happening? Are there risks? Are we all, what are the issues? So there will be a view on the local authority, there's a view nationally, and then we stick them all together. So I hope we are starting to get that better, and I think hopefully Directors of Public Health recognise I've sat in their shoes, which is probably not the case for previous organisations.
Particularly around track and trace, where I think the biggest strain came there. So
there is a point though on the test and trace, just for awareness. So I know you will hear one narrative one side, and I will hear another one another. In fact, a moderate way into the pandemic, when we had, I think it may have been the Omicron surge or a later one, we'd started, so there was a national contact tracing system, and Directors of Public Health said we can do this better. We handed bits of it over, or test and trace it, I don't think I owned it at the time, and they said, yes, this is very good, and then they said, stop please, we can't cope with that. And actually what it signals is you need the right balance and flexibility in the middle, because actually Directors of Public Health can't do it all either. If you have something which is really significant, you have to have some sort of national complex system to manage that. But trying to get the handover is the bit that's important.
Yeah, the other question I want to ask is about kind of resilience of workforce, because clearly we know there's a significant vacancy level in social care and also in the NHS. And my experience of working alongside NHS staff is that they're completely burnt out as well. And if another pandemic was on the horizon, as we've heard it could be, we could see a mass exodus. How are we ensuring that the staff have got the resilience in order to be able to endure another pandemic?
Really good point, and I recognise that. My own teams, we had people who it's actually a content problem as well in terms of memory legacy, because people stayed on for the pandemic who perhaps were retiring, and then those worked through, and a few people left early because they were worn out. All of a sudden you've got an exodus of really experienced staff at one time. So actually maintaining a throughput, if you like, a flow, and building up scientific and technical careers take a long time to build, so you can't just go and find another 10 infectious disease consultants or the equivalent Directors of Public Health. There is quite a lot of work going on. I do it with my own health protection teams. I know Directors of Public Health have, in trying to almost, recognise that problem and the sense that people have got very worn out. Some people find it really traumatic going back over some of the work that they did in the pandemic. It was so fast moving. Obviously clearly for NHS staff on the front line where they were dealing directly with individual patients, that's totally recognisable. But I think other people felt just as directly involved, responding to calls, managing outbreaks in care homes and things. So absolutely recognise. I think we need to recognise it. Clearly people need to be supported at work in the environments that they are. And I think the most important thing for this committee is to recognise that there has to be a steady flow of the right technical people coming through, and you can't just switch them on and off. It's really important for all aspects. We find it particularly in our laboratory staff. We can't just suddenly go and find 20 people, and once you get below a certain critical mass, you can't run a laboratory.
Brilliant. Okay, finally you have a patient, Paul Blomfield, who's sat waiting.
Well, I'm conscious of time, but there's a couple of kind of different questions I'd like to ask. During the pandemic, there was a lot of discussion about the different approaches different countries took, not least Sweden. And everybody said, well, we won't be able to assess it in the short term, we can assess it in the long term, of who got things right, or at least where different decisions might have been better. Are we at the point now where we can learn anything from other countries in terms of where they might have got things better than us or not?
So I think on different topics, yes. I mean, I think at the time many people said, and I would sort of stand by it, which says actually each individual country often has very different characteristics. So, I mean, if you take New Zealand, put down a complete lockdown for the whole country, but even within the country, you have more sheep than you have people, everybody's spaced out, it's a very, very different environment. The UK is a travel hub, which is good for some things. It's not very good for, infectious disease risk and the proximity of individuals for transmitting infection. So it's quite difficult to compare individual countries, but there is some learning. I mean, my point would always be you can always learn from another country, full stop. There are some interesting points, I think. So the week before last, we had Gulf CDC, Centre for Disease Control, is just starting off. So this is 6 areas, 6 states around the Gulf. That's very interesting. So we're working with them. They're developing a new organisation. And so they're coming to us because we're quite experienced and they want us to share our knowledge. But of course, they have detailed knowledge of infections that we don't routinely see. So there is always an opportunity when we're doing these exchanges, and we have memorandum of understanding with all sorts of public health institutes right across the world. Some countries particularly we are very interested in, and I think are recognised to have done a very good job. So Korea, for example, is very good on data and its laboratory and testing capacity, and we are working with them directly. So my Chief Scientific Officer has been over. We have a memorandum of understanding with them. I'm going over in about 2 or 3 weeks because as they grow a new organisation, we are as well. And the way that they are approaching opportunities for getting ahead of vaccine development and testing diagnostic assays is exactly, we think, the same way that we're trying to. So I think there's an opportunity for us, in 2 different parts of the globe to be really progressing that agenda forward together.
Thanks very much. That's really interesting. Completely different question about long COVID and indeed the long-term impact of the virus on people, which haven't necessarily presented as long COVID, but there's kind of speculation about what different impacts, as any virus might well have, could have. What learning are we doing there?
So it's not an area that I'm personally directly involved with, and so I'd probably refer you more to the NHS, where they manage the clinical oversight of that, and through the support they give to patients will have more detailed information. But nevertheless, there is research available, and I think some of the more recent findings published in the last month or so was around cerebral function going forward in the longer term. I think we still have a few problems with nomenclature and getting, we're back to baselines, who's the affected group and what does that mean in the longer term. There was a significant amount of research funding went in through NIHR around the autumn time in 2020, and much of that data, primary care information, it sort of picks up the question earlier about what's happening to these individuals, was slightly later in, so it was easier to monitor, if you like, to start off with hospital patients, and then it's difficult to try and distinguish what the severe hospital impacts are, intensive care admission, which would routinely give most people some sort of negative longer term outcome, if you like, from what the impact of COVID is. So those studies, I think, are still not through to publication. I would expect many of them to start to come out over the next year or so. But there will be a lot of confounding factors in them, I think, which will lead on to more studies. Clearly, there's also more of a sort of molecular level understanding around inflammatory processes as well. And again, not my specialist area, but lots of research work ongoing.
Thanks very much. Can I ask one final question? Again, something completely different, but you'll have seen that the RCN, among others, have been arguing that we should be bringing back masks in response to the JN1 variant. Now, as I understand it, the JN1 variant isn't particularly more damaging, but it is getting around quite a lot at the moment. What's your view on mask wearing in health and care settings? I mean, given that, JN1 variant or not, there's kind of a lot of respiratory viruses going around all the time. Is it so foolish to think we might encourage it more than we are?
So JN1 is around 85% of the variants that we're currently sequencing. Of course, we're not sequencing many, but I think that's a reasonable representation of where we are. As you say, it's not particularly significant. Most of our populations, and I'll just come back to immunosuppressed groups, most of our population is very well protected now, and those who are most vulnerable, of course, have had additional vaccine programs, and we have treatments. So I think where we are moving to is treating COVID, because there isn't really a differentiation now between COVID and other respiratory infections. So the answer, the question for me is, how would we treat a respiratory infection normally in a healthcare setting? And that depends on what is happening in that environment and what the population affected are. And I think the RCN statement came on the back of when JN1 was new. Effectively, it was around December time, and they were flagging WHO advice. But actually, if you look at the detail of WHO advice, it says universal masking, but it says universal masking where healthcare workers are dealing with COVID cases in high levels of transmission, or not quite the right wording, but it effectively translates through exactly to the position for advice in healthcare settings, which I might add is given by NHSE, not it's their operational advice. But basically what you're saying is you risk assess what that situation is. So if we're in a dip and rates of viral infection are low and you've got a fairly average hospital population, you would just apply whatever is normal to apply. So if you're aerosol generating procedures, then you should be using a respirator. That's normal practice. If there are low rates around and you're sitting in an outpatient department and you're not expecting people to have COVID infections, then you treat it as we would flu or anything else. The one area where I think it's different is where you have immunosuppressed patients. So you'll have some wards with immunosuppressed patients, and hospitals will know how to handle that, and it's left to the discretion of the hospital, of the individual trust, each of which will have a director for infection prevention and control. They will assess the situation, and if they want to understand more about the local epidemiology or prevalence, they will come to us and we link with them. So that's how it's left. It's for the local trust to decide what is appropriate at that time in that healthcare setting.
Thanks very much.
Right, we're in good shape. We said we'd finish at 6, so final word is to our guest today, Greg Clark.
Thank you very much indeed, Chair. I'm sorry you have to have a double dose of me in a week, Dame Jenny. You heard Sir John Bell talk about the inevitability of another epidemic of some sort, and you agreed with that. And you probably heard his kind of memorable phrase that things should be always on in terms of the preparation from that. Last week at the Science and Technology Select Committee, we talked about testing and the fact that we've had 2 labs that have been contracted, the Berkshire and Surrey NHS Trust and the University Hospitals Plymouth NHS Trust, to provide that. Their contracts, as you know, come to an end this month, and therefore they won't be always on. Will you be able to revise the termination of those contracts to make sure that we do have that always-on facility for testing?
I think, and I'd need to confirm, I think the actual contract full expiry date is to the end of June, but you're or provision if you like, but you're right. And the key point is about, and I'll probably say similarly to the comment I made at the Science Committee, which is we are always on as a health security agency. We're on 24/7. We can scale up. We can start that initial testing. We have scientists on tap 24/7 to be working should something come through. We can scale up rapidly to around 4,000 tests. We can go up to 20,000 with NHS labs fairly quickly. The 2 labs that you mention are designed to go that next step up. And then beyond that, because actually if you were looking to provide, we had something like 850,000 PCR tests per day during the pandemic. Now there's, as I mentioned at the committee, there is an issue about how you deal with this. Do you say, actually, that's what we want to do? and have that on tap, because that will be, for ministers to decide, an extremely expensive intervention to have on tap. Just to have the RFL effectively flat, not doing anything, and not directly ready to go, costs £500,000 a month. So I think, so my comment to the Science Committee, and I'd perhaps make the same one here, is there is a national decision to be made, which is clearly not just for me, which says, you know, at two extremes, one could say, right, we're not going to have it, we'll have whatever the UKHSA has got, and we will have a scalable boundary. That's what I'm definitely trying to deliver. So we retain the teams, a small team who know how to scale things up if funding and resources are available, which is, there's a knowledge element here as well. But you could have just that boundary and no more, and then build it if an impact happens, which is a bit like the last pandemic, but slightly better, one would hope. Or you could say we're going to run everything hot, and for a population of 65 million, we'll maintain that output. As I pointed out, my guess is that there's somewhere in the middle, and that is for, I think, for government to decide. It's clearly not for me, because there are opportunity costs associated with investments on running things hot, if you like, and keeping them ready to go. So it sounds a very simple thing to do until you start putting the costs of that in, because it multiplies. You have to have all of the supplies on tap as well. And for something like the RFL, actually, one of the considerations for that is that equipment changes. So let's suppose, you know, the pandemic doesn't hit for 5 years, much of the equipment would be obsolete. So you've actually got to maintain and keep changing the equipment when you don't know whether you're going to use it.
We were talking about these two organisations that are currently contracted, not necessarily the RFL. And perhaps kind of finally this leads to, so you just indicated this is a decision for ministers rather than for your agency. And indeed you said to our committee that your organisation is responsible for assuring its own preparedness for the things within its remit, not the totality of the country. But your strategic plan, which was published last year, says that the UKHSA aims to ensure that the country is prepared for, and when feasible can prevent, future health security hazards, including pandemics. So is it the case that the UK Health Security Agency is responsible for, as it were, certifying the preparedness of the country?
No, I think I'd go back to what I said at the Science Committee. In fact, the oversight for pandemic preparedness sits with the Department for Health, and the comment in our strategic plan, and there is a very carefully phrased when feasible, because clearly there are resource implications as to what you can do generally, but we work with the Department of Health and can support that very strongly. So our aim is to ensure that the country is as prepared as possible, but it will be within a framework of whatever is decided should be that level of preparedness.
Leave it there. I just note that the when feasible was for can prevent. There was no qualification to the UKHSA being responsible for ensuring that the country is prepared for future pandemics.
I think it says aims to, and we absolutely do. We're working directly with the Department of Health, and it goes back a little bit to the start of this around clearly we're wanting to see what the public inquiry recommends, but there is a portfolio of work looking at not just, for example, respiratory viruses, but 5 different routes of transmission working upstream. And we hold some of those strands of work. So there are about 4 or 5 which sit with UKHSA around things like, you know, diagnostic assays and what have you, and others which sit with the Department of Health.
To finish where the Chairman started, I think it would be, in my view, imprudent to wait for the conclusions of a public inquiry that's not going to finish till 2026.
We're not. That work is, just for absolute assurance, that work is ongoing. I think it's more likely that a final plan will come out once we have some of those early works, but the work is ongoing.
Okay, thank you very much, Greg. Thanks very much, colleagues, and Professor Dame Jenny Harries, who's Chief Executive of the UK Health Security Agency. Thank you for your time this evening. Order, order.
Meeting is currently suspended. The proceeding has ended. 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 The proceeding has ended.